Okay, everybody, welcome to the Advance Rhode Island CTR Clinical and Translational Research Seminar Series. My name is Sharon Rounds. I'm the Program Director for Advance Rhode Island CTR, and it's my pleasure to moderate our program today. We have two really wonderful speakers, both of whom have been receiving funding in the recent past from Advance Rhode Island CTR. So we're very excited to hear about their work. The first speaker is Joanne Wilkinson. Joanne is an associate professor of family medicine and a health disparities researcher. She has, up until recently, been medical director of a large primary care clinic for diverse underserved patients in Pawtucket, Rhode Island. As I mentioned, she's recently been funded by Advance-CTR to assess health behaviors and uptake of diabetes treatments. We're very pleased to have her present to us today on diabetes health equity for urban Latinx populations. So take it away, Joanne.
Thank you, and welcome everybody. Can everyone hear me okay? Sharon, can you hear me?
Yep.
Okay, perfect. I'm just going to jump right into it. Today, I'm going to talk to you about the background and rationale for the project. I'm going to talk about our year 1 and year 2 activities. This is a 2-year project with a lot of moving parts. I'm going to mention everything that we're doing in the 2 years today, but I'm going to really kind of like hone in on a couple of parts of the project that I want to talk more about. I have no conflicts of interest and nothing to disclose. This project was funded by CTR funding for both year 1 and year 2. So type 2 diabetes is common, as you all know, in the United States, and it's disproportionately common in Latinx or Latino communities. There have been recent advances in diabetes care and newer diabetes therapies that have really transformed the landscape of diabetes treatment, but it's not clear how well those advances in diabetes care have penetrated to all communities. It looks like because of uneven insurance coverage and some early adoption by specialists and not necessarily primary care, that these newer therapies are not equally accessible to everyone. The 3 new therapies that we're focusing on for the purposes of these 2 years of study are continuous glucose monitors, CGMs, which are worn on the skin for 10 to 14 days and provide real-time information about blood sugar uploaded via a receiver, usually to your phone. The second one is low-carbohydrate diets, which I think people are probably familiar with, but it's a significantly lower than previous dietary recommendations amount of carbohydrates. And the third advance are GLP-1 drugs, like Ozempic, Victoza, Zepbound. These medicines are usually a weekly injection. They mimic glucagon-producing sense of fullness, and they've been studied in heart failure and renal disease. They're also used a lot for weight loss, but often only covered for diabetes. So those are the 3 treatments that we were interested in, sort of how are these treatments penetrating into sort of urban Latino communities in the area compared to sort of everyone else. And so our research question was, what are the barriers and facilitators to the use of the newer diabetes therapies, those 3, in urban Latino patients? And when you think about this, I just kind of wrote this whole cascade of like, when you think about how a new therapy gets used by a patient, there's lots of places where it could go wrong, right? The physician has to think about it. It has to occur to them that it would be good to prescribe this, and then they have to prescribe it for the patient. The patient has to feel sufficiently motivated to pick it up from the pharmacy and try it. When they go to the pharmacy to get it, the medicine has to be covered by their insurance. It has to be available at that pharmacy. A lot of GLP-1 drugs are back ordered. The patient has to know how to use it and understand kind of the schedule of dosing, et cetera. The patient has to try it. Sometimes people don't try it right away. And then 2 things could happen. The patient could have a good experience with the medicine or a less good experience, right? If they have a good experience with the medicine, ideally they refill it and continue using it. Sometimes they don't refill it because even though they had a good experience, they don't understand that the medicine is meant to be used long-term. If the patient doesn't have a good experience with the medicine, Ideally, they go back to the doctor and say, hey, it didn't go so well. I had side effects, or it fell off, or I didn't understand how to use it. And they get some teaching and feedback and they learn how to use it, or they start over with a different medicine. But a lot of times that doesn't happen. They just don't refill it and they go away, or they don't go back to that doctor, or they don't mention it. So there's a lot of places in this cascade where things could go wrong. And we're really curious to find out through mixed methods research sort of where the issues may be. This is a very busy slide. It outlines our year 1 and year 2 projects for this series of work. Year 1 focused on 4 main aims. We did a systematic review of the literature focusing on CGM prescription initiation and use in primary care settings. We did some community building in partnership with Progreso Latino in anticipation of our year 2 work, which is almost entirely with them. We're engaged in a secondary data analysis of the practice-based research network data, which has been updated to include newer therapies and more granularity about race and ethnicity in the patient population. And we developed a survey that we're going to use in year 2. So a lot of the year 1 work was kind of preparatory for year 2. In year 2, we're conducting a mixed methods project to look at data on barriers and facilitators to CGM, GLP-1, and low-carb diet use from 3 data sources. So we have kind of different ways of looking at the problem. The survey, which we're going to administer at Progreso Latino's food pantry, qualitative interviews living in the catchment area of Progreso and Clínica Esperanza, and the quantitative data from the year 1 PBRN analysis. This is a summary of the year 1 projects. We have a different team working on each project. I can give you the sort of 10,000 vote view here. The systematic review is done and we're submitting the manuscript this month. The PBRN has been a very long and arduous data extraction process, and it's still going on, but we're learning a lot through doing it. And once we have the data, it should be pretty straightforward. The community building, I'm going to talk in a little bit more depth about today because it set us up for year 2. And the survey development was done in consultation with some of our colleagues from Advance-CTR. The systematic review, I could literally talk for like 150 hours about this systematic review, and our team has spent more time than that on it. I'm going to give you really like the quick flyover overview. We were interested in prescription initiation and use of continuous glucose monitors in primary care. We pulled out 1,200 plus abstracts, and through a series of elimination criteria, winnowed them down to 17 studies that we used for data extraction. These 17 studies were mostly randomized controlled trials, and the outcome was not CGM use. The outcome was improvement in diabetes, and the CGM was part of the intervention. And so the study was not powered or aimed at collecting data on are CGMs useful, palatable, wearable, et cetera, but there was sometimes some kind of implementation science process data collected about the CGMs that we looked at for this study. This is our Prisma flow chart, mostly put on here just to show you that we did the work properly. There were a lot of rules and regulations around systematic reviews. Our team worked really hard on this. And the studies were from a range of countries. We limited them to only primary care sites. The main point of this slide is that the studies were RCTs, and really none of them made a specific effort to include patients from minority populations. And in several of the studies, it was a very low number of non-white patients that were sampled. And of the few that looked at underserved populations, they had very small sample sizes. So there really isn't a lot of useful data about Latinx populations specifically from this CGM review. We basically found that adherence to CGM use seems to be related to patient satisfaction. I'm kind of going quickly through this slide, but satisfaction is very difficult to measure. Lots of different sort of scales and methods of measuring satisfaction were used. It was very heterogeneous. It's hard to kind of make much out of this data, except to say that it looks like patients like wearing continuous glucose monitors and find them helpful. And that may be related to them being likely to continue using them. But not enough data was collected on not enough patients, and certainly not enough Latino patients for us to really know sort of how it's working in that population. So it's interesting that so much work is being done on interventions that include CGMs, but not very many studies have been done on CGM use itself. And is it useful, palatable, doable for most people? In terms of our secondary data analysis, The Practice-Based Research Network, I'm sure many of you are familiar, contains data from several primary care practices within Care New England, as well as a local network of health centers and some private practices. Dr. Eaton, who was working on this before I was, presented some data from the PBRN in 2022, which showed some disparities in diabetes outcomes between white and non-white patients. Non-white is a very bucket term, but it means Black, Latino, Portuguese, Native, and other patients in our PBRN. As I just finished saying, the latter group was very heterogeneous, and so it was hard to draw conclusions about any one of those groups. However, understanding these data is complex given that they're pulled from Epic and other EMRs, and the data entry was not done with research in mind, it was done with clinical care in mind. So it seems straightforward, but like, who is a patient? Are they a patient if they've been seen in the last 3 years? Are they a patient if they've had a physical in the last 3 years? What if they just came for colds? Do we include them in the data analysis? What if they were listed as having diabetes 3 years ago, but it's never been updated? Did it go away? Did they have bariatric surgery? Was it really gestational diabetes? There's a lot of kind of granularity to sort of sift through to figure out which patients to include in the analysis and which outcome variables, et cetera. And the new data pool not only includes information about different meds and CGMs, but it's for a different time period. And it attempts to separate out some of the ethnic and racial things that we're interested in. However, if any of you have ever worked in an EMR, you know that it can be very flawed. Like, language preference can be a very flawed variable. Race and ethnicity can be very flawed. And it really depends on how patients identify themselves and also whether they bother to fill out that data or really understand it. So it's very tricky to get the data pull correct. And we've been spending many, many months on it. Ideally, what we're hoping to show is to look at rates of GLP-1 and CGM prescribing in Latinx patients versus other groups, and also to show some granular data on where the prescriptions initiated and were they filled and refilled. In other words, did patients continue using them? In the previous analysis, it looked like race and ethnicity and maybe zip code and some of the sort of social SES type variables that associate themselves with zip code were strongly associated with diabetes outcomes. But what we're interested in is sort of getting a little bit more granular on language preference and more granular on zip code. In parallel to this, the research assistant who's working on the project with me is an MPH student, and she is doing a sort of similar analysis using NHANES data. So she's a little further along because the NHANES data is already cleaned. And she's looking only at Latinx identifying participants and analyzing what factors are most strongly associated with uptake of GLP-1s, language preference, insurance status, or something else. So her data will be very interesting too, and will complement the work that we're doing here. In terms of other products from this data analysis, we also want to generate like a table 1 type data poll showing demographics, diabetes, and health-related data for Latinx and non-Latinx patients who live in the zip codes of Pawtucket and Central Falls. In the community partnership, which I'll talk in more detail about in a minute, one of the questions we had was, are we going to uncover anything in our project that would be of interest to Progreso Latino for other things? And we offered them this, and they indicated that they'd be very happy to have it to help them write other grants. And so that's just kind of a nice thing that we can do for them. I also think that as we go through this data and clean it and think about sort of the PBRN and its utility, we're going to gain a lot of knowledge and perspective on the limitations of pooled EHR data to answer research questions and unique issues to Epic specifically, which will certainly help me in my future work, but may also help other researchers that are using the PBRN. I want to take a couple of minutes and just talk about our community partnership work, because I think that's been the most fun part of this project, although I love data too. Our goal was to partner with Progreso Latino because they're the biggest and best known service provider to Latino patients in the area. And I haven't done a ton of community partnership work, but when I've done it before, it's really important to understand the goals and priorities of the community partner and how things work there and what they're already doing, because you would never want to duplicate work that they're already doing in the community, and really try to build off of their strengths and find out what they think areas of need are as well. We want to ensure that the work we do both benefits them and their community and also isn't disruptive or redundant to their existing processes. This is a very busy slide, but it kind of sums up some of the things we did in year 1. Initially, we had a meeting with the directors and staff at Progreso Latino and sort of They gave us an overview of what they do, what their programming already is for health and diabetes, and we learned a little bit about how they're funded. Essentially, the programs that they run are grant funded. Their infrastructure is maintained through donations. And also ask them, like, what programs do you think you'd like to add or expand? One of the things they said in the initial meeting was that they would like to do more with mental health. Mental health isn't a focus of this project, but it's something that I file away for the future, for potentially working with them again. And also set up expectations about how we would communicate. And it was a very interesting initial meeting because one of the first things that we both sort of said was, your diabetes classes are great, but what about the people that can't come to them? What about people that are working or taking care of a family member and they just can't get here for that many hours per week? And the director of Progreso Latino is very interested in enhancing and sort of democratizing this teaching around diabetes to make it more accessible to more people. And we both were sort of very excited by the idea of creating something asynchronous, like a short video module that patients could watch on their phone, like when they're riding the bus home from work or when they're cooking dinner at night or something like that. And then along the way, we also hope to provide them with data they could use in future grant applications. We built in some donations to our Advance-CTR grants to support some of their ongoing work. And we also said to them, like, what do you want or need from like the department that we're based in that you're not getting? And they specifically said, like, we'd like for the Family Care Center, which is my clinical base, to know more about us, and we would like to know more about them and sort of partner with them more explicitly to help serve our patients. And so then we attended some health classes at Progreso. There's 2 classes, the diabetes prevention program and a class called Tomando Control de su Salud that's sort of similar about healthy eating and exercise. And we talked to the instructors and participants in those classes, which allowed us to see the curriculum, which is excellent, but not specifically focused on the newer diabetes therapies, and also to get a sense of the demographic of the people who are attending and what they get out of the class. We also went to Progreso's food pantry, which before I went, I sort of envisioned that it was like a room at Progreso Latino that was like open all the time and there was food there and people could just drop in. The food pantry actually functions more like a giant busy farmer's market that only happens for like 4 hours a week on Wednesday. And people take a ticket and they go in sort of groups of like 40 or 50 at a time, and they can go through these lines and pick out food. It's just super busy. Hundreds of patients come every week. And as soon as we saw it, we were like, this is obviously going to be the best place to recruit because there's a lot of patients that get to the food pantry every week that don't get to the other services at Progreso. We then met with our community engagement and DEI leadership at Care New England to try to initiate a more ongoing relationship with Progreso independent of our research work, and to really make it sustainable, to not commit to something that we really couldn't do or that the people after me couldn't do. And we basically created a little bit of an experience in the residents community medicine rotation where they go to the food pantry and also to some of the senior days at Progreso Latino and take blood pressures and sort of answer medical questions. And so we volunteered at that senior day program. Progreso has started a program called SASASA, Salud, Sabor y Salsa, which is like focused on healthy eating, healthy movement, and improving your health. And so the diabetes initiative that we sort of hope to create with this research project really fit well with that. And so we're trying to partner with them around some of those activities. Being at the senior day just increased our visibility and sort of trust capital with the participants at senior day. They recognize us, they know who we are, particularly my research assistant, who's very bubbly and maybe on this call, I don't know, is very well liked with that group. And she's been several times. And so that really helps our visibility with them. And then the last thing we have done so far is we met with Progreso Latino and also the Knights of Columbus, where the food pantry is based, leadership to help problem solve some of the logistical access issues that we anticipated in advance of recruitment. So we were thinking, like, initially we were going to have our survey be like accessible via a QR code for your smartphone. Having met a lot of the participants at senior day, we think that we're going to have a paper version of it too, which is fine, but I'm glad we know that now. You know, initially we thought that we might do our qualitative interviews on Zoom because it auto transcribes and it's very convenient. having met some of the participants there and seen what their internet access is like and what their technology knowledge is like, a number of these patients are older, we felt like on-site interviews would be better. And on-site interviews at the Knights of Columbus would really be the best. And so we went and met with them and established a room that we could use, et cetera. So it was really helpful to do all this advance work, not only for sort of visibility and trust capital, but also to think through the logistics to make sure that the study would be successful. Very briefly, we developed a survey that we're going to administer at the food pantry in consultation with some of our Advance-CTR colleagues who really helped us think through, like, what are we using the survey for? What do we want to find out from the survey? Are we going to do the survey first and then the interview? Are we going to have it be for the same people? Will they be intersecting populations? A lot of stuff to sort of think through before we made it. And what we decided was to really keep the survey short, to try to administer it to a large number of people at the food pantry, some of whom might also do the qualitative interview, but not all. And we really focused on things that were quantitative and could be answered in a survey format fairly easily and quickly. We had initially had a number of Likert style questions around, like, do you feel like you understand your doctor? Do you feel comfortable asking your doctor questions when you're in the visit? Trying to get at sort of advocacy and patient engagement. We ultimately took those out because we figured that those would be better for the qualitative portion of the project, because people can really talk in more depth about sort of what those concepts mean to them. And so we only left 2 questions on there. Do you feel comfortable asking questions? Do you remember what was discussed? And then the other questions on the survey really relate to the 3 new diabetes therapies. Have you ever heard of this? Has your doctor ever prescribed it? Are you using it? And we asked some questions about whether they had language concordance with their provider, and who they're going to for their diabetes, and then some demographic questions. So it's pretty short. It's 2 pages paper. So I know I'm going pretty quickly, but I just want to briefly outline year 2. We have 2 main components in the year 2 project: the survey, which I mentioned, and then some qualitative interviews, which will either be conducted at Progreso, the Knights of Columbus, or at our building in Pawtucket at the Family Care Building, or Clinica Esperanza, or we can do it by Zoom. It's been a multi-step IRB process because I have these great Brown students, but it means that we have to do reliance agreements with Brown, and take my word for it, it took a long time. And so we have a wait list now of about 10 or 12 people that want to be interviewed, and the reliance agreement just finalized like 2 days ago. So right now we're in the process of calling all of those patients up to schedule their interviews. The qualitative interview guide is very basic and sort of what you would think an interview guide might be like for a project like this. Tell me about your diabetes. Was it hard for you to sort of get used to the idea that you had it and make behavior changes, et cetera? Tell me about your diabetes management. What do you currently do? And then a little bit about sort of, have you ever heard of these new treatments? What was your reaction? Would you use them? What would it take to sort of, get them into your hands and get you to use them? And then, did we forget to ask anything else? We have not yet done the first interview, but we have some preliminary qualitative data from another source that I'll get to in a minute. So what we're hoping to do with all of this is to ultimately use the data from year 1 and year 2 to develop some asynchronous educational modules. This is going to be like another grant in the future. And what we think it will look like is 3 to 5 short videos in Spanish, focused on closing the gap for the newer diabetes treatments. And so the content of how the gap is going to get closed will depend on what we've been told in the survey and what we've been told in the interviews. Do they need to be more empowerment videos? Like, when you go to your doctor, ask them about these meds because they've never mentioned them to you before? Or do they need to be videos that are more like, we know your doctor has mentioned these meds several times, but you need to grow your comfort with them, and so we're going to teach you about how they work. The content style and dissemination will be based on the information that we obtained here. We did think a little bit about sort of what the videos should look like and what style they should use. And in order to sort of assess that while we were waiting for the IRB stuff to finalize, we were able to do an Advance-CTR studio in June to poll some potential participants about format and style. So it was a great experience. I'm trying to go to my next slide. Oh, here we go. I only have one more. We showed them 8 videos that we found on YouTube about different aspects of diabetes treatment with a variety of formats and styles, some more funny. they had a variety of regional accents and speakers. Some of them were like a role play type format. Some of them were like a lecture. Some of them had like, chalkboard type graphics, etc. The participants who Advance-CTR does all the sort of recruiting and logistics for the studio. It's really amazing, and I'm happy to talk about that more in the question section. We had great participants who were very thoughtful and had a lot of great things to say. They tended to like both the sort of chalkboard type videos and also the kind of looser interview type videos. I thought that people would like these kind of trusted friend type videos, like I have diabetes too, and I did this. Actually, the participants saw those as less trustworthy because they sort of said, well, that worked for her diabetes, but it might not work for mine. And I would rather hear from a doctor, Overwhelmingly, the majority of participants in the studio had never heard of CGMs, GLP-1s, or low-carb diets. Their doctors had never mentioned them. Some of them had heard about them from other people, family members, etc. And so I was really curious about that and asked whether they all had language concordance with their physicians, whether they spoke the same language, and they all said yes. But there was a little bit of low-level kind of mistrust for some of the participants with their physicians. For example, physicians didn't explain the rationale for changing a statin dose, and the patient thought like that maybe the doctor forgot or didn't know what they were doing. And so it really speaks to the issue of how important physician-patient communication is and how important it is that it be transparent and correct and to take the time to do it right. The other big theme that came up in the studio was patients talked about how there are all these different aspects to managing your diabetes, and that for them, it really felt like assembling an individualized plan had to resonate with sort of who they felt like they were, their identity, sort of what felt, organic and helpful to them. And it was very much, they rejected the sort of one size fits all phenomenon of diabetes. And so those were just kind of two kind of touch points from the studio that helped me think about thematically how to structure videos or education for this population. These are our study team's emails. Petra and Jasmine are two terrific MPH students who are working with me on the project. We have a study email for people who are interested in potentially participating. So if you know anyone, you can have them email the study email. Also, each of us has a Google phone number for the study. That's not on the slide, but we can give it to you if you send us an email. And I will stop there for questions. Thank you for listening.
Terrific. Thank you so much, Joanne. Let's see. We have a question from the chat. Do you anticipate bringing these findings to the providers to increase the likelihood of them initiating the conversations with patients and explaining the rationale, et cetera?
Yeah, definitely. That's a great question. And it wasn't the focus of, when you write a grant, you want to make it sort of simple and pointed at one thing. So we just put the patient education materials in the grant, but I definitely think that doing some provider education will be really helpful, at least doing it sort of in a conference lecture poster type format. But I would also like to create some educational modules for physicians around some of these issues. It could be multifactorial why physicians are not mentioning these therapies to people, including primary care physicians' own discomfort with some of these methods and, maybe not having been fully trained in them, et cetera. But yes, we would love to do that.
And I have a question. I was impressed by the extent of the partnership work that you did preparatory to beginning the research project. I mean, it was a lot. How long did that take? And is that the sort of thing that that funding agencies would provide funding for, or do they expect that to be done prior to writing a grant application?
Well, we were lucky to have this work funded by Advance-CTR, so I feel like put a plug in there. It was a multi-step process getting this funded. We had originally sort of written it as one proposal, and the way that the funding worked out, we were encouraged to split it into 2 years of work and have the first year be kind of most of the preparatory stuff. And so with that, kind of framing of it, we really thought a lot about, well, great, if we had a whole year to do all of our community kind of participatory research set up with Progreso, then the second year would have a much greater chance of success. And so we really thought about kind of what are the pieces that we want to have in place with them. And it took a couple of revisions of that section of the grant, because initially it was like, we're going to go out and make friends with them and it's going to work out, you know? So then we thought more granularly about sort of what those components would look like. We're lucky that CTR funded us to do it. And we're lucky that we were able to write a small donation to Progreso Latino into the grant, which isn't paying for the grant stuff that we're going to do there. It's more just a donation that they can use for a related, you know, project that they think is useful. But I think that kind of partnership work is really important, partly because you want to be a good steward to the community, and partly because you may want to do work with them again in the future, but also you want your data to be right. You know, you want it to be really reflecting what's going on in the community, and you have a better chance of getting a wider, you know, kind of group of participants and having them be more honest with you, I think, if you have that trust capital.
Okay, great. And what was the acceptance rate of the video information? Did it depend on, did it vary by gender and age?
I mean, we only did the one studio. Everybody there was an adult. They all had type 2 diabetes. I think it was a range of ages from like 40 to 70. I didn't see that within that small group that there was a lot of difference by gender or age, but it's obviously, you know, very small sample size, and they were all talking amongst themselves. So it's hard to know.
And unfortunately, we're going to have to move on to the next presentation. There's another terrific question in the chat. Joanne, maybe you could respond to that.
Yes, I'll respond. Do you want me to respond? Well, I can say it quickly while she's setting up her slides. Online is how we want to disseminate it, because we want it to be accessible to the highest number of patients possible. What we're envisioning is like, and this isn't final, but like Instagram, maybe, Latino radio and podcasts, maybe, and Progreso's website, maybe.
Okay, fantastic.
Thank you.
Thank you so much. And our next presenter is Thaís São João. I hope I'm not mutilating the pronunciation of your name. And she is a nurse researcher at the University of Rhode Island College of Nursing, where she holds the rank of assistant professor. And she has been also funded by Advance-CTR with a very interesting pilot project that's gotten a lot of interest from the media and also from congressional delegations. So Thaís, tell us about commercial fishermen in Rhode Island, a pilot study on cardiometabolic health and productivity. Thank you. And questions in the chat, please.
Thank you, Dr. Vance. It's a pleasure to be here and to share that. So good afternoon, everyone. Thanks for joining me today. Dr. Vance already presented me, so I'm a nurse, I'm a professor at URI. And before we begin, I would like to give a big shout out to my team. I have mostly amazing collaborators here. So Dr. Colio, she's my mentor and co-PI. Azure Seigler, Jen McCann, they both from the Graduate School of Oceanography here at URI. And I have my amazing nursing students, Madeline, Katie, Kelsey, and Taylor, who have helped me over this time. The picture you're seeing right here is Point Judith, where I have been spending a lot of my time lately. And it's one of the top 10 ports in the US, right here in Narragansett. So this project is supported by Advance-CTR, and of course, what I'm presenting here doesn't reflect NIH positions or opinions, and I have no additional competing interests to disclose. So beyond the NIH grant, this project has also received supplemental funding and a lot of support from several organizations. URI College of Nursing Internal Funds, the Commercial Fisheries Center of Rhode Island, Land and Sea Together, and the Rhode Island Department of Environmental Management. Without all those organizations, this wouldn't be possible. So I'm super, super thankful for all of them. We also received all the necessary approvals from URI, IRB, and IBC. And I'm just gonna give you a little background of how we got here and why does this matter from our perspective. So U.S. fisheries sector is a highly significant contributor to the economy in the U.S., especially in an ocean state as Rhode Island. So it generates over 50,000 jobs and billions of dollars in revenue. And among all the workers in the economy, commercial fishermen, they are the ones who face the higher risks because they deal with a lot of implications, physical implications, psychological implications, and a lot of exposure to weather and to diverse conditions that really can modify their health outcomes. So two reports bring a lot of information, two local reports from Rhode Island, and they really helped us base and locate the situation as a problem or at least something to screen. So just let's look very quickly at some statistics regarding the economic aspect, because that's how we linked the productivity here. So the latest report we have in terms of licenses and jobs, it's from 2019. And at that period, we had 150 commercial fishing businesses and 1,200 and over license holders supporting more than 5,000 jobs. And solely, only those commercial fishermen in Rhode Island, solely, they were responsible for a revenue of over $100 million and more than 59 million pounds of fish. And by fish, I mean all types of catch and landings that you can imagine. We have a number of varieties in Rhode Island. So without that being said, this study was driven by a very critical rationale. We felt like fishermen are often overlooked, and the way they are exposed and their health really impacts how they work, because their work is highly correlated to productivity, right? If they don't fish, they don't have a revenue. So in order to fish, they must be healthy. So it's almost like they are this invisible force bringing food. And if you think about them, I'm very passionate about it, so bear with me. If you think about them, they're really the last hunters that we have. This is the last wild catch that we have. So everything else comes from, we actually grow things, right? And raise, but they really go there and face all those challenges. So surprisingly, no public data is available on fishermen's cardiovascular health or health behaviors overall in Rhode Island or across the country. However, global evidence shows that they deal with a lot of stress and cardiometabolic risks, chronic stress, and altered sleep patterns, altered dietary patterns as well. So our aim is to fill this gap, to be able to generate information. So of course, this is a pilot study. This is the first picture of what's going on. So our primary goal is twofold. First aim is to investigate cardiovascular health, quality of life, lifestyle behaviors, and the risks and protective factors of this community. And then examine these associations with productivity to see if these impacts or it doesn't. We are assuming it does because of global research, but we still need the data to prove our point and be able to deliver or tailor interventions for them in the future, right? So to achieve our aims, we developed a mixed methods study, expecting to have commercial fishermen that at least they had to work for a year to be a little bit acclimated with the profession. And if they couldn't respond or understand, or they have any type of disabilities that they couldn't talk, they were not able to be included. So our first phase informed the second phase. And the first phase was mostly composed by qualitative phase. So we conducted focus groups with semi-structured interviews and open questions what do they think about those concepts? How do they see them? If they feel they have more risk or less risk than others. So we had a lot of important conversations about it. A guide was developed with the help of the Bird Corps, especially Rochelle Rosen, which was a huge help for this step. And then we recorded, transcribed, analyzed, and coded. And I'm gonna show you in a few slides a bit of this results and what we find here. And then finally, we adjust phase 2 based on what we heard and learned from phase 1. And then this is the actual survey phase. So our sample size calculation showed that a sample of 59 will be adequate for that. So recruiting fishermen can be a real challenge. And I have been doing surveys for a while, but this was from far the biggest challenge in recruiting that I have ever faced. But luckily, we have very good partners with fishermen's leadership and the DM. So they helped us a lot recruiting and disseminating this research. So we are going to 3 ports, mainly Point Judith, because it's really the biggest one. But Newport and Davisville are very specific too, so they are considered very important for us. We started this data collection, everything, all the phases back in January, but we're still ongoing data collection. We haven't finalized that yet. And then I'm just gonna go quickly over what variables we're looking at. So our primary outcomes are really looking at who they are. So ages, sex, gender, partner status, race, ethnicity, previous diseases, and all those, gathering that information. And then we are using a tool proposed by the American Heart Association, which is called the Life Essentials Aid. So it's major formed by 4 health factors and 4 health behaviors. And it's a measure that ranges from 0 to 100, 100 meaning an ideal cardiovascular health, and 0, when you approach 0, it means that you have a poor cardiovascular health. So this metric allows us to add additional measures, which we have done. So not only we are using that measure, but we also added a questionnaire for physical activity, a CDC measure for nicotine exposure, some objective measures to correlate with sleep health and diet, and biomarkers as well. So a part of that, we have secondary outcomes as well. I'm still talking about primary outcomes. So we are looking at the fish landing because we want to correlate that with their health, right? And their productivity. So that's how we're measuring. So we had to actually create a questionnaire with 14 questions. And they go from like very specific situations of in a day that you were supposed to go fishing and you couldn't, how do you manage, and things like that. So types of fish, how do you measure? So it's 14 questions regarding that. And then for the biomarkers, we're using the dried blood spot, and we're measuring LDL, A1C, blood glucose, and insulin to correlate that as well with their data and also how they respond to the surveys, to the questionnaires at all. And then as for now, the secondary outcomes, we're looking at the quality of life using the Huckel Breath questionnaire, which is a very known, established, valid questionnaire. So we want also to look at the well-being, social relationships, and how they perceive environmental conditions. And we changed an initial questionnaire that we have for the SLIC, which is the Simple Lifestyle Indicator Questionnaire, because we are very interested in comparing how we look at those behaviors using Life Essentials Aid, but how they respond here, because we can add more information here regarding alcohol consumption, smoking, and stress, which all were very highlighted as important issues during the focus groups analysis. So this data, of course, it's very sensitive for many reasons. So we won't be able to share publicly, but this will be stored in the URI repository. And of course, we are glad to share whatever we can with other researchers by demand. So our goal is to perform a logistic regression model, considering that ideal CVH or cardiovascular health will be our reference category. And we're gonna use covariates like age, gender, BMI, race, and ethnicity, because we know it's very well established that those factors, they already change how people respond to many of those related questions, health-related behavior questions. So we will also plan to categorize in 2 big groups, ideal and non-ideal, and to see the difference, because this will also help us to identify potential health disparities and areas for interventions. We are not assuming they are all similar or they have equal behavior, right? So I'm gonna present very quickly some of our preliminary results from phase 1, the focus groups. So this is the output after the coding and our analysis and validating among the researchers group. One of the things that emerged were how they perceive chronic diseases. So here, the first column, you can see the codes, but actually the second one is really about what the description. So what do they mean? So if you think about personal history, we ask them, what do they know about their health? And very surprisingly, or not so much, they really are not aware of any cardiovascular history of their own or their crew. Because I also had the opportunity to talk to captains, and they feel very responsible for their crew, and they're not aware of anything. And this is really concerning if you think about it, because many times they are far, far away, overseas, right? And if something comes up, we should be aware, ideally, right? So that's another concern and probably another research, but it is there. So we also observe there is a tendency to deny those risks. They are very hard workers, very brave, very well intended to care for this population, but they do not do a great job taking care of themselves. That's our first impression. So lots of reports on injuries, trauma, a lot of chronic pain. And then regarding fishing activities, often they will go for short travels. Some do like day trips. A lot of them do over up to 10-day trips as well. And they perceive fishing as an amazing experience. It's very peaceful when they are overseas. They really like being away. One thing that I learned that really struck me is that they are very strong and bonded community. They support each other, and I was very touched when I heard that being a fisherman is not a profession; it's a lifestyle. It's who they are. And as a nurse, I could relate to that very much. So the other theme that emerged was stress, which we were not predicting before this focus group. So what they share is that there's a lot of stress related to insecurity and not knowing if they're gonna catch enough to have what they need to pay bills, mostly. So it's a lot of stress from that. There's another added stress from all the paperwork that they now have to do when they come back from the sea. So there's a lot of reports, a lot of digital sites. So weighing fishes, measuring, making sure they're informing the right size, the right amount that they are allowed to catch and bring back. So it's a lot of time also that consumes from their day. Imagine that they have been fishing for like 10 days. And when they come back, they stay 2 hours writing reports and organizing things and sending to storage, to freeze, to sell, and everything. So it's a lot. And they feel that despite a lot of support that ports have, especially Point Judith is amazing in terms of support for fishermen. This specific part at the end of the day, it can be a lot of demand. So the last one, not the last one, yeah, the eating piece of that, or the diet nutrition aspect, it was very surprising to me, because they shared behaviors that you would not typically expect from mostly males in their 50s, right? So it's a lot of snacking. They don't have time to have a proper meal during daytime. So they will try to have a healthy, or they will say decent meal by the end of the day, with actual fish that they catch or chicken. The boats are super equipped with fridge and oven, all sorts of facilities that you can imagine. So they do have things in place to have healthy meals, but they really prioritize the time for working instead of eating. So that's also very impressive on my end. So a lot of reports of caffeine-based beverages, candy, things that you would not think that they would be interested in eating, but they do, because they're quick and they will bring energy, right? So, and then sleep was another one that was very surprising, because they shared that they actually sleep better on the boat than ever at home, because they feel like when they're on the boat, they are also super tired and they take turns. So very common, one stays awake and then everybody else goes to bed, and they will take turns. And probably because they're so tired, they sleep better. There's also something with the boat and the sound, and like the noise, the background noise. But what they share is also that when they are at home, they think a lot about problems and what is their next day bringing. Are they able to fish tomorrow, and things like that. So it's a lot of interesting aspects that I have been learning. So regarding our limitations and challenges as we move, we need to recognize that we have a very limited geographical sample, even if this is a pilot project in Rhode Island and we were very intentional about it. It is still a limited sample size and area. We also recognize that it may be some aspect or some degree of social desirability in terms of participants responding what they believe we want to hear, especially being health workers. And we also consider the mere measurement effect. So at some degree, we don't know if the simple fact that we ask questions may change their behavior. For the challenges I mentioned, the recruiting, it has been really challenging, but it's also very rewarding to have them. And it's very related to their availability and the weather, as many times, and I have been learning this. So now I actually cheer for windy days, because I know when it's windy, they're not going overseas, and then they probably will be working on the boats, and then we can approach them. However, not every day the forecast is correct, or accurate. So eventually, they plan not to go, but then despite the wind, the weather is nice and the sea is good, so they will go anyway. So eventually it will happen that we have someone scheduled for an interview and they cannot make it because they have to go. So it's a lot of flexibility. And then as future directions, I'm very proud and glad to say that this, to our knowledge, this will be the first study to examine cardiovascular health and quality of life and relate that with productivity in commercial fishermen. in Rhode Island, but also in the US. And so far, no relationship between those things and how this may affect economy, especially blue economy, was established. So we hope to be able, not right now, but in the future with a larger sample size, and trying to do a deep dive into those. And also, mostly importantly, for me, is to establish a link between nursing research, healthcare, and fishermen. And in the very near future, we hope to pursue federal grants to maximize the reach. And ideally, my goal for the next couple years will be to establish a local health policy, or some of them, that would protect and ensure they have health access. Because we already know that this will probably also impact their productivity in a good way. As for our products, this is the first paper from this research. It's a very detailed description of the protocol or framework, if you will, and you can access that using this QR code. It's also open access, so it's pretty easy to find if people are interested. And finally, I just want to say a huge thank you to many people. And I'm very afraid I'm gonna forget someone, but I need to acknowledge and thank my research team, my fishermen participants, because they're very kind and respectful, and they really can see the importance of this work. URI College of Nursing, of course, Advance-CTR, Emily and her amazing staff, and a lot of people that have helped me during this pathway. Michelle Swallow, Monica, Fred, and Shay from Commercial Center of Fisheries of Rhode Island. This will never happen without them. Sarah and Carrie and Jenna from the DEM, and Rochelle, and of course, I have the best collaborators in Brazil, which are still working with me. So I think we do have some time for questions, I hope.
Little bit, yes, thank you so very much. That was really terrific and very, very interesting.
Thank you.
So a number of questions from the chat.
Sure.
Joanne, Wilkinson, our previous speaker, asks, notes that fishermen can be a challenging group because of lack of insurance and their irregular schedule. Running out of meds and not being available for testing was a big challenge. Our system is not really structured to accommodate these challenges. I'm wondering if your participants had any ideas about how healthcare providers could be more responsive to their needs.
We haven't talked about
a future study, perhaps.
Yeah. So I never ask them if they have any ideas about how to overcome those challenges. I do have a lot of ideas of integrating healthcare workers with our different characteristics to build together a center or something where we could embrace them and really help, because especially Rai, we are so close to the beach and to the coast where they are. So hopefully we will be able to gather people together to help them.
Okay. And how do the demographics of the fishermen community in Rhode Island compare to that of the greater US?
This is a very good question, but it's kind of, I'm not sure if I'm able to answer, because I only, now we haven't analyzed any data because it's still an ongoing data collection for the survey phase. And unfortunately, there is no public database on fishermen across the country. So I cannot compare at this point. I do have an idea of who they are in Rhode Island, but I can't compare right now. What I can say for now is that they're mid-50s Many of them are white, more than I thought they would be. They are not highly educated in terms of years of schooling, and they're actually way more fit than we thought they would be initially, because it's a lot of exercise, right?
Yeah.
So they're super strong. Yeah.
So another question, do you plan on looking at health behavior scores independently, as well as a composite score? And how does loneliness relate to these health behaviors?
Yeah, so we can look at the health behaviors and factors individually and just describe them, but all of them combined, they will form the Life Essentials 8 metric, the American Heart Association metric. So it's a two-way of looking as a whole and then individually. And yes, we plan to look at them both ways. Yeah.
Okay, and well, we're a little over, but I have to ask a question about sleep since that's part of my practice. And I'm
Sure.
interested that they slept better in the boat because I would think that this is shift work. And shift work frequently requires changes in circadian rhythm. And I'm wondering if in a future study, perhaps you might actually measure sleep with some onboard sleep monitors.
Yeah, that's a great question. And you wouldn't believe my face when I first heard that. I was like, really? Really? Because I would never thought that too. But and it wasn't like one person, it was the whole group.
That's really interesting.
It is, yeah. And I feel like there's so many areas to cover. And I would be very interested in getting together a team that will look at those other things as well, because they're gonna emerge, and we probably could definitely look at having meters with them to see how they sleep. Because they may feel they're rested, but we're not sure, right?
So we have lots of great comments praising both presenters in the chat. I want to thank everybody for joining us today. And our next Advance-CTR seminar will feature a distinguished clinical translational researcher, Dr. Susan Ku-Uven, who will be talking about studies of cervical cancer in underserved areas. So, and the global burden of HIV, HPV related cancers. Thank you. And so thanks everybody and have a great day.